Thank you all for inviting me to talk about some preliminary work that I'm doing with Sahan Dissanayake, who's my colleague at Portland State University and also affiliated with the EfD, and Jeff Klein at the U.S. Forest Service. So this project, in contrast to much of my other work, is U.S. focused. So we'll learn a little bit about the Pacific Northwest in the U.S., but also I have a secondary goal, and therefore was especially happy to give this talk because I think that this approach and this topic could potentially be a good one for EfD. So I'm hoping this could spur some ideas for work by EfD. So this talk and this topic is about direct contact with natural areas. And of course, the direct contact by humans with natural areas, it offers a variety of ecosystem services. Of the four categories of ecosystem services, that direct contact probably provides three. Provisioning, of course, so you take out food and fiber, non-timber forest products, timber, and things like that, harvest of grasses, perhaps. And then regulating services, anything about the ecological integrity of the environment that supports human well-being somehow. So, for example, better air quality, improves respiratory health, disease regulation, anything like that. Cultural services, so anything to do with your kind of mood or enjoyment that you have would also perhaps be affected by direct contact. So actually people going to the natural environment to get ecosystem services of one sort or another. And so of these four major classes of ecosystem services, which I suspect everyone is familiar with from the Millennium Ecosystem Assessment, health turns out to be a really important one and really linked to those outcomes. You might remember from the Millennium Ecosystem Assessment that the kind of the ultimate outcome there are really basic things like material well-being, freedom and choice, social relations, security. And so health is linked with that. So anything that affects health, any linkage between the natural environment and health, that's going to lead to these key outcomes that were identified in the MEA. So the research and policy I would mention has focused in a number of aspects of this. So there's a large literature on the effect of just simply living in a greener area. And a lot of that work, it's all observational, I believe. A lot of times using satellite measurements, using NDVI, and then overlaying maps of health outcomes. This is probably the most common approach, observational, using this type of data. But some, are more, and you see here in a study by Jeff Donovan and a colleague. Jeff Donovan works for the Forest Service. He's here in Portland. You see here digging in a little deeper. What does that green look like? Is it biodiverse? Are they native species? And they find that this difference, not surprisingly, perhaps, if anything matters, would be important. Infectious disease prevention, where I think this is one we hear about a lot, especially in the international context, biodiverse environments and just natural environments, potentially reducing the spread of malaria, though, Jonah Bush in World Development and colleague has a paper that questions this. So nothing is clear here, but these are the areas that are being looked into. And then a really interesting area that I had just encountered, not really economics at all, but just the chemicals that forests emit, especially there's a couple classes, but one that is in the focus of research and believed to be important are terpenes, a class of chemicals emitted by forests. And a colleague here in Oregon at the Oregon Health Science University is actually um, buying these terpenes, concentrating them, and then she's a nurse. She's a faculty member who's in the School of Nursing, and she actually brings these chemicals into the hospital for her patients, cancer patients that are um, suffering pain, and she's putting them in a humidifier and exposing them. I think she said just not very much, 1 hour per week to this and evaluating the effects. So that's not observational. And so that's a randomized controlled trial like what we're going to try to do. And so that's in terms of kind of the way things are done. Um, but several health issues have been explored, and the evidence is intriguing. It's intriguing. Um, so researchers have found that being in greener areas, so a lot of it, so you see here, the article that I noted here is about greenness, living in green areas. But amazingly, they found adjusting for everything else, higher birth weight, higher average birth weight, reduced hypertension, uh, so lower blood pressure, less respiratory disease. Perhaps that's not surprising because of the air filtration function of plants and especially trees. Pain management, found people that live in greener areas have less pain. And then diabetes, lower diabetes, cardiovascular disease, some effects on cancer, though that's such a long-term one. These are issues that have been explored. Nothing is certain. This is a very incipient and very, I guess I should say, a nascent and very interesting, at least I think, line of work. And then on the mental health side, this is probably where the evidence is strongest. ADHD, um, especially in kids, attention deficit hyperactivity disorder, especially in kids. It seems that spending time just outside, but especially outside in natural areas, can reduce ADHD symptoms in kids. And then the other three as well, anxiety, stress, depression, and some researchers have linked that with not hypertension, but blood pressure. They sometimes find lower blood pressure um, when people spend time in nature as opposed to a human dominated environment. Of course, EfD has been involved in this. Don't know, haven't checked on the status of this, but we do have a special issue that either has come out or is about to come out on the economics of the impacts of natural ecosystem loss and degradation on human health. And I think a number of you contributed to this special issue. So that's very exciting. My recollection here is that all the papers are observational in one way or another. You typically using not, I think, 100% using quasi-experimental methods. So if contact with nature is so great, potentially, if it can improve human health, then maybe it should be part of health treatment plans. So maybe this is something that healthcare providers should consider as part of their toolkits. And so here we have a paper also for U.S. Forest Service is very involved in this, and that's why we're partnering with them. Excuse me. So, so this leads us to the topic at hand of nature prescriptions, or as they call them in this paper, green prescription. So, this has started in the US, Canada, and maybe elsewhere that I don't know about. Um, Physicians or other medical providers, not just physicians, other medical providers too, have begun providing prescribing time in nature. So here, the U.S. National Parks Foundation is promoting this and has some resources on a website for both physicians and patients. And then here, this is a guide from UC Davis uh, for healthcare professionals, how to prescribe nature and what are the potential benefits, suggestions for writing a nature prescription. A lot of focus on the actual paper, on the prescription. As you'll see in our work, we're not necessarily, that's not the main focus. I have a live link here. Let's see how things go. See if this comes up okay. Yeah, so this is Park RX America, which is a nonprofit in the US, and they have a lot of resources for both providers and patients to educate about time in nature. And they're, they have, as you'll see, they have research here. So these are all studies. Increasing outdoor play in preschools reduces body mass index. Access to nature lowers rates of obesity and depression, and so forth. So they're championing this: decreased diabetes, hypertension, improvements in cardiovascular health, improved sleep. This is going to be a focus of our work. Some things on immunity. That's kind of like the work of the colleague on forest compounds at Oregon Health Science University. Decreases in asthma, and then for providers as well. So making the case, of course, the evidence, and so forth. And so a lot of things. So this is a kind of a something with some legs here in the US. And so we wanted to look into this and hoping that EfD is interested to get involved as well. So that's kind of that's Marin County, county in Northern California, north of San Francisco, has a quite robust park RX program. RX meaning taking, is abbreviation from Latin word for taking, and British Columbia as well. So not that this is a gigantic movement, but there is some policy work in this area. So these are just some of the things. Oh, I guess here I had a link to the Park RX site, which I won't use, but these are some of the things that nature prescriptions or just ordered time in nature may be able to do. So why do this? Well, as I mentioned, and maybe just go into a couple more details, mental health. This is phrased strongly. This is taken from a literature review. I would pull back from this. I don't think any of this is established, which is why we're interested to be involved. But there are certainly hints on mental health, maybe even improving cognitive function, relaxation, less stress. On the physical side, um, physical activity, now that's a mediator, really. The outcome, it would be cardiovascular fitness, perhaps, or something else. But clear physical potential physical effects, even affecting kids in utero. Emotional well-being, stabilizing mood, and just kind of helping focus. So independent of mental health, but just allowing people to just improving quality of life, perhaps. Environmental benefits, which are a little bit different issue. But oftentimes time in nature, people often don't go alone. And so, they'll meet people that share those interests. So this can potentially promote interactions between people, which we know is very important for human well-being. And here in the U.S., where I am, there's a really serious issue of reduced connections between people. So here's what we're doing. We're doing a pilot in the U.S. state of Oregon, where I live. And this is a collaboration between my university, which is called Portland State University, and Oregon Health Sciences University, a particular group there called the Oregon Rural Practice-Based Research Network. Let me take a moment to talk about ORPRN, because they're really interesting. They are a research group, a grant-funded research group at Oregon Health Sciences University. But what they do is they partner with clinics that are interested to participate in research to potentially give them some new ideas that they might implement. And so we got connected with ORPRN, and we're really grateful that we did, because we are having a lot of trouble here in Oregon. We needed to have access to patients somehow in order to do this work. And we had a lot of trouble doing that. But ORPRN, with those connections, and they knew the clinic directors and so forth, we were able to do it. And part of it is that Oregon is with the exception of Portland, where I live, it's a pretty sparsely populated state, a lot of small towns and a lot of open spaces. So these rural clinics and rural people in general can be a bit isolated. And so we've found that they've been really interested to engage to kind of just get some ideas and some outside fertilization. It seems to be an important motivator. So where's Oregon? We're right there, right above California. Probably most of you know this, but just in case. So we're on the western side of the U.S. Part of Oregon is borders the Pacific Ocean. Washington State is to the north, and you see it's a very big state. It's a large in size. To drive from west to east would take you probably 7 hours by car on good roads, 6 hours. And we only have 3.5 million people in the whole state. So it's in terms of area, it's a highly rural state. So the purpose of this work is to examine and try to test in a pilot setting, the effect of nature-based prescriptions on patient adherence to exercise and self-reported wellness. Now, here in the US, and I think around the world, everybody's supposed to get more exercise than they do. Our US Centers for Disease Control has recommended that people get 30 minutes of exercise in a day, 5 days a week. So 150 minutes per week of exercise. And most people are not getting even close to that. So everybody needs more exercise. And so we're going to look at that, and adherence is an issue. So we're going to look at that, and we're going to also look at self-reported wellness. Also importantly, we want to evaluate the research design, and we want to troubleshoot the implementation. As you'll see, there are there's some steps to this, and we're not the first RCT looking at nature prescriptions, but we're definitely one of the first. And so there's a lot of outstanding implementation issues. So our approach, and this is one of the largest mountain in Oregon, it's called Mount Hood, sort of right in the middle of Oregon. So our approach is a randomized controlled trial with 2 clinics identified by ORPRN, and all patients will receive a recommendation for exercise by someone from the clinic, a provider, and then also be referred to our study team if they would like to. And half of those patients are randomized to exercise, and the other half just any exercise, and the other half are suggested to do their exercise in nature. And as you'll see, we have some suggestions for people. So here's our clinic sites. Here's Portland, where I am. This area here is a big valley. It's called the Willamette Valley. So these are the populated centers. Eugene right now is where the U.S. track and field Olympic trials are going on right now there. So this is the populated part, and then this is sort of, there are cities like here in Bend, but a lot of this is empty. So we are working with a clinic in a small town called Klamath Falls near this is the California border. And the other one is here in the mountains in a place called Enterprise. And I had thought that naively, perhaps, that if people live in, rural areas, they have nature everywhere. They must be getting out into nature all the time. And it turns out that at least in Oregon, that doesn't seem to be necessarily true. Maybe everywhere. Rural people in Oregon tend to not get into nature. Probably, maybe, perhaps even less than in the Willamette Valley in the Portland area, for example. So what are we doing? We are doing this RCT in these two clinics, as I mentioned. We're going to recruit a patient pool of 84 adults. And these adults have to have one or more chronic illnesses, and I'll talk about exactly what those are. All of those patients will receive a recommendation for exercise, which is completely non-controversial because everybody gets that recommendation all the time. They'll get that from their actual doctor, their provider, or other clinical staff members, plus a referral to project staff. And then half of these will be randomized by our team into nature or just general exercise. So that's the basic setup. And so we're going to recruit these patients from these two clinics. And I just want to emphasize that we are focusing here on chronic health conditions. That's our focus. There's a lot of different focuses you could have. Sahan Dissanayake, my colleague, and I were previously, looking into working with cardiovascular patients. I think that could be an excellent patient population to work with for this, for a number of reasons we can talk about in the Q&A if you want to, but we weren't able to. So we're working with chronic health conditions. So that's, if you're interested in doing anything in this, that would be one place to start, is what health condition, what patient population are you wanting to focus on? So a key issue we confronted right up front is, what is nature? What's the definition of nature? So, that's going to depend on the ecosystem in which one operates. Here in Oregon, we have forest ecosystem. In the West, really big forests, species, Western red cedar, hemlock, some redwoods in the South. So big trees. As you go further east, the rainfall declines, and so you'll see more pine species and other species. But the strongest literature is on the effect of greenness on human health. So we insisted that, we wanted green in our definition. We think that it should be a green place. And both those places, Enterprise and Klamath Falls, they do have those. They're not necessarily around everywhere, but they're numerous. There's forests there. And then ideally, some of that time should be, it should be with trees, and at some time covers 50% of the sky. So 50% canopy cover. We want to see that sometimes, so that, and that's because in much of the work has been in denser forests, and because that with the more canopy cover, it seems that it creates a feeling of serenity and may reduce stress. So this is our definition. There's not an accepted nature prescription definition. And part of the reason, I think, is multidisciplinary nature of this. I would not say ecologists have got into this space quite yet. It's mostly driven by doctors who are focused on the prescription piece. At least my experience is there. That's the focus. So for our studies, these are brochures that are for Portland that we have prepared. But we want to give people some guidance about where to go. They could go wherever they want, but here we want to have some things in our back pocket that we could suggest. So here's a little introduction on nature prescription. Now this is only for the nature prescriptions treatment. The control, they won't get any of this. Okay, so we want to fully inform the treatment group about the potential health benefits. So we don't want to keep that a secret. We did some work using City of Portland data, found out where the Portland parks are. We chose the top 20 so that people could have a lot of room, and figured out where they're located in the city. So, and then here's a list of them on the backside of this brochure in the different quadrants of Portland. So we thought it's important to give people some interest, so some information. So it's got the address of the park, how you access it, some other resources, and then we also created a website. So we got that same pie chart where the parks are. And here you can find a distribution of Portland parks according to each section of the city. And so here, this is just pulling out. You click on the southwest part of this, and this pops up, and it gives you the parks in Southwest, and each of these are hyperlinked. And over here, there's a map where people can see some of those parks. So we want to give guidance, not dictate in any way where people do their exercise, or even if they do their exercise, but to give people the resources that they might need. And so we don't have, at least my understanding is we don't have this quite yet for our 2 sites, but maybe we do. One of our team members may have taken care of that already. So how are we going to implement this Nature RX study? Well, we're going to have 8 weeks of data collection. Everything is through our institutional review board. We're ready to start any day now. And what we're going to collect baseline, end-line, and 6-month follow-up surveys. So we'll have the survey element of this. And those surveys will focus on baseline wellness, socioeconomic characteristics, experience in nature, this type of thing. We're interested to see if over time, if that does behave, if there's any habit formation, just indicative in evidence of habit formation. Does the behavior seem to change at all over this timeline? More importantly, perhaps, is the patients are going to keep daily logs of their exercise, their sleep, their self-assessed wellness, mental health using, gosh, I can't remember what they're called, screeners, these mental health screeners for anxiety and depression, to see if maybe there's some relationship between the time in nature and these scores. And then our students will check in with them weekly. They'll keep these logs and maybe even fill out surveys using Google Forms. But we expect that some of the patients, maybe many of them, they won't have that capacity or just want the connection, want more intimate connection with the project staff. And so our students are going to reach out to everybody weekly, and we'll be prepared to manually enter these data into the Google form if necessary. And then the key outcomes that we're looking at is exercise adherence, frequency, and average duration. So as I mentioned, we all know we all need more exercise. In the US at least, perhaps even a majority of people are sedentary. So this is a key outcome. It's a mediating factor, but it's an outcome that we're mediating in terms of health, but it's one of the things we want to look for. Again, habit formation. Is there any novelty effect here that gets people moving a bit more than they would otherwise? And then self-reported mental and physical wellness. We're not going to, we have no access to patient medical charts. We're not, nothing invasive, but self-reported. And then sleep quantity and quality. One of our collaborators at Oregon Health Science University is a sleep expert, sleep researcher, and he thinks that any effects we find will be mediated by sleep. And particularly, he thinks that light, just simply getting out into outdoors where the light is so much more intensive than inside, will improve sleep. And that's his personal hypothesis he wants to look into. So we'll be very interested in if there is any correlation with sleep. So our recruitment goal, we're going to try to phase in these recruitment over the course of the summer, about 6 patients per week over 7 weeks for each of the clinics. So there'll be 42 patients per clinic. And in terms of eligibility, they have to be adults. Here in, at least, well, I think in the US in generally, but at our university, certainly, it's a whole different ballgame if one is working with children, who can't give consent themselves. So we're only working with adults. They have to give informed consent, formal informed consent, oral consent, not in writing, but oral. They have to have at least one chronic condition, and their providers, this is a multidisciplinary effort, many disciplines here. And so we're not the ones to evaluate whether a particular person can safely do moderate exercise inside or outside for 30 minutes a day. So that's going to be the provider. The provider is going to evaluate that. And so here's the chronic conditions in Oregon. This is from the Oregon Health Authority website. And you see that of adults, over half the adults in Oregon have one of these chronic health conditions. Obesity, 31%, so really excessive weight. High blood pressure, exactly the same percentage. Depression, more than a quarter. Arthritis, we're not going to include arthritis because we don't see in the literature any effect with nature prescriptions. Asthma, 12% have more than one. 12% of the Oregon population have that. Diagnosed diabetic. Chronic heart disease, stroke, heart attack, 8%. Cancer, we're not going to include that either because it just is too complicated. COPD, chronic obstructive pulmonary disorder, about 6%, and then anxiety. I don't know why we don't have a percent there, but significant percentage, probably similar to depression. And then these are the codes. So I didn't know that this was key. Our partners at Oregon Health Science University said that these providers, they need a code. So we gave them medical codes. So if patients have any of these codes, they're eligible. And so the recruitment process will work like this. The providers at the clinics will identify these patients by looking through their charts. They call it scrubbing charts, and kind of provider meetings. They call them team huddles, and then introduce exercise as a treatment option and tell them about the study. So introduce them. Probably this is going to be, for most people, it's going to be one of the many times they've been asked to exercise more. And then confirm that the patient is interested in participating. And then give the prescription, provide the prescription and refer them formally to the study. So that's the process from the clinic side. And so there we have two kind of ways this could occur. And one is going to occur in one clinic and the other is going to occur in the other. And this just purely has to do with their preferences. So the first one, so-called active recruitment, is to identify the patients, introduce the study, confirm the patient interest. The provider makes the prescription, formally says this is what you should do. Register them and provide the patient contact information to our study. So that, I guess that's here. And then once they're with us, then we take over, and our study team then gets that informed consent, randomizes them into the treatment or control group, and then we collect the data. We do the baseline, end line, and 6-month follow-up survey, and we did weekly data collection. And this occurs, except for that end line, except for the 6-month follow-up, this occurs over 8 weeks, 2 months. So for the active recruitment, this is the script that the providers will use. And they compare, if we've told our partner clinic in Enterprise, Oregon, the Far East, that really wants to do it this way, we said you can paraphrase this, but just get the key elements. So basically the 30 minutes daily exercise, let them know that they're partnering with us and they can participate in this study if they want to. Briefly tell them what they're going to have to do. They keep this log for them. They get what's on there. And that's their main requirement. And there's also some information about stipend that each participant gets. The other clinic did not want to do it this way. They said they're too busy. So the first parts are the same. And then, except they're going to provide these, it's not so much a prescription, but like a postcard that then gives them information. I'll show you a copy of it, or a draft copy, earlier draft. And then the patient enrolls himself. So the provider doesn't enroll them, the patient enrolls themselves. So this is not as good, but it illustrates, at least what we found, are the complexities of this. Like, these clinics they're busy, they have different interests, they have different ways of doing things. In our discussions with Orprin, there's been a huge focus on not overburdening clinics, not expecting the providers to keep track of anything. So that's that, so we ended up with 2 kind of processes, and it'll give us a chance to see which works better, but it's unclear to what degree the data can be completely combined. So here's this postcard I mentioned. For the hybrid workflow or hybrid recruitment, say you're invited, you can participate in this exercise-based pilot program, not nature. We've got nature here, but not in any of the instructions, because half will be randomized in the control. And then here's this prescription. Now, in the clinic in the East that's going to do a more the active recruitment, they are going to create a custom prescription, like on a prescription pad, and the provider's going to sign it. So it's going to be very formal, much more formal than this. So it probably will be more effective, we think. But here we'll have a QR code that can be scanned. We'll have a website information here. We'll have email, phone. We're not going to have choices here. In the Q&A, I can let you know where this came from, but we're just going to have the 30 minutes minimum, 5 days a week, 150 minutes. And so, as I mentioned, this active recruitment is preferred, because then the provider is directly, it's closer to a true prescription. And we've emphasized that any staff member can provide this recommendation. We just want the imprimatur of the clinic and the medical staff somewhere to refer them to us. So that's what we're doing. We have no data. We haven't collected this. We're starting up. We're set up. Um, so my pitch to you is the following. In many EFD countries, I know outdoor recreation is significant and in many places increasing. And also chronic diseases are serious problems, as well as other other non-chronic diseases that could be amenable to nature prescriptions. Though I think that chronic diseases are probably the best. And notice that cardiovascular disease is one of those. So I would suggest that EFD centers could potentially implement similar studies if people were interested. I think this could be fruitful. I know that traditions about rigorous outdoor exercise could differ across countries, but the benefits are likely similar, and I would guess that in some places in all countries, providers are recommending exercise. Again, a lot of studies do not focus through exercise as we're doing, so one doesn't have to do that. That's just our focus. That's just our focus. And perhaps it's a bit easier to get such a study off the ground, out in other places. As I mentioned, this has been pretty tough to get this going, but I suspect in other places it might be a bit easier. So could be if people are interested and thought that this could be useful, and you could interest critically healthcare providers to help to partner. Perhaps this could work well. So I think that's all I've got. Yes, thank you very much. So I'm happy to take any questions if
Okay.
anybody has any.
Yes. Yeah. So thank you very much, Rand. So the floor is open for comments and questions. You can also, put your suggestions in the chat box if there are any. Yeah. Okay, Rand. Maybe let me just kickstart whilst we wait for others to come in. So, what I wanted to be clear about was the definition of this nature, exercise, vis-a-vis what you described to be the normal, or maybe the traditional way of exercising. Maybe if I get a distinction, then I'll be more clear on my question.
Okay. Yeah, there. What the healthcare provider is recommending is exercise. In our study is they're recommending exercise, and so that could be some. I guess I didn't give any examples of that, though we do have that, and we emphasize to the patients that they can do whatever they like. They could do. Most people probably will do walking, right? So probably it could be walking. It could be yoga in nature, perhaps. It could be stretching. It could be, other, kind of deep knee bends or anything that they want to do. Could be bicycling, though that could be a little bit more difficult in nature. Maybe mountain biking, perhaps. Could be more rigorous hiking. So any type of exercise. And then in these RCTs, a really critical point is that everything, to the extent possible, everything needs to be kept the same except the treatment. And so we've tried to do that, though it's hard. It's really hard to keep patients, even that have the same diagnoses, truly constant. But we tried to do that. And then everybody gets the exercise recommendation, and just half of those will be directed to try the best they can to do that in nature. So
Okay. So maybe before I go to so in that context, if I understood you correctly, so this is similar to, let's say, walking in the woods or maybe on the hills. I mean, something very close to, maybe a green area as you define. I mean, do you see, the possibility of some kind of a spillover? Because let's say I may not exercise, I don't know how many kilometers that I have to be away. I mean, in terms of defining your control, like how many kilometers one has to exercise away in order not to, experience maybe like the clean air that is coming from, the green area vis-a-vis someone who actually exercise within that green area. Yes.
mhm. Yeah, well, that's where the kind of the prescription aspect comes in, Philip, because it's totally possible that people in the control group, they'll go outside. And I should have mentioned that on our daily log form, we ask where they exercised. We ask where. So we should know. We'll know if they actually exercised and where. So we can adjust for that in the regressions. But it's people are free to exercise wherever they want.
Yeah.
But remember that probably our number one outcome metric is the adherence to exercise, because that's a huge problem. Adherence is a huge problem. Let me give you a more extreme example. Like when we were exploring doing this with cardiovascular patients, these are people that have had heart attacks. So, they almost died because of these problems, and they're recovering. And at least in the US, there's a set regimen, 12-week regimen, including certain drugs and then increasing exercise over those 12 weeks to kind of build up. In the US, at least, only 15% of people complete that program. So adherence is just an amazing problem in healthcare. And these providers were saying that they have a lot of difficulty getting people to take obviously life-saving medications. So adherence so there's a significant human behavior element here, which is of course why we're interested. And habit formation and all these things play in that we look at in other contexts.
Okay, thank you. So I go to Amin.
Yes, thank you, Randy, for such an important topic that you presented here. And you alluded to the possibility of extending to most of EFD centers, which is quite useful. But my concern is with the maybe adjoint late, the randomization. That how do you do to make sure that the ethical concerns are addressed? For instance, those who are randomized to go to get the exercises in nature, how was it done? To ensure that everybody have the opportunity to be chosen into the treatment, but not just by the fact that the way you did it, then they got into treatment, and those who are in control didn't get a chance to get into treatment. That's one. And the second one is about maybe I didn't follow clearly the chosen clinics where the patients are coming from and how close they are to nature. If you want to, exercise, in a nature perspective, is it a distance you have to travel and that can discourage you to do that and stuff like that? That was useful, yes.
Yeah,
proves
thank
out.
you. Thank you. Thank you. I mean, yeah, I think, Cape Town, I think that's definitely one of the locations that I have in mind as a good possibility. So I would be interested in exploring if others think that this could be a possibility. So on the randomization, we wanted to take that out of the provider's hands because, of course, they're going to recommend the nature to the people that they think would benefit most, right? So that's why they refer the patient to nature and to us, and then graduate student who's going to handle this is just going to use simple even odd randomization. And we have different scripts. So when she randomizes someone to the control group, she'll read a script to them and get their consent. And they don't know anything about the nature side of this. And then so the next person would be in the treatment. And so they get a different script and they get all this stuff about where to exercise and access to the website and the brochure and all that. So that's how we're doing it. Because it's a study, we think that everybody would benefit from being in the treatment, but we're not going to do that. We're not doing that. So maybe we won't find out because the sample size is too small. We would like to have follow-on study with a large sample size and a more robust structure, including some time in labs and sleep lab, for example, and more access to patient information. So a bigger study. We won't get anything conclusive. We just want indicative at this point. And then in terms of the clinic's location, yes, that's a great point. And so we've, in our guidance to the patients, we're saying to, choose some places that are within 20 minutes drive of your home. And we know because of our contacts in these places that's possible. They should be able to find places closer, but we wanted to make sure that they could do that. And yes, but this is part of the real world, right? Most of us, majority of the human population lives in urban areas, right? And so nature is not out of the doorstep, right? So this is just like one of the factors that, people will have to pay costs to get these benefits if they exist. But in our particular locations, and in fact, even in Portland, we could send people from any location in the city within 15 minutes to one of the top 20 parks. So at least in Oregon, it should be possible, except there's a large arid area where there really are no forests or limited forests. Those would not be good candidates.
Okay. Any other comments from the audience?
Mhm.
I'm not seeing any hand. And okay. So thank you very much, Rand. Yi, do you have something to say?
No, actually, but
Okay.
thank you. Yeah, thank you,
Okay.
Randy and Philip.
Okay. I think there's a hand. Maybe we can take that last. So George.
Just to say thank you. Thank you.
Okay. Thank you. So Rand, thank you very much. And thanks to everyone too. Bye-bye.
Yeah, thanks for having me. Thank you for listening.
Okay.
Hope to see you all soon.
Okay, thank you. Bye.
Thank you. Bye.
Bye.